We were studying about abdominal migraine, and now we have another case here of a 50-year-old man who comes to emergency with abdominal pain which began suddenly about 1 hour ago. The pain is now generalized, constant, and extremely severe. He lies motionless on the stretcher, is diaphoretic, has shallow rapid breathing, abdomen is rigid, very tender to deep palpation, has guarding, X-ray showing free air under the diaphragm. What is the single most likely diagnosis? So this is a case of perforated peptic ulcer. Definitely, it is a picture of an acute abdomen. X-ray shows free air under the diaphragm, which is classical for a perforation case. The patient is lying motionless and having a rigid, tender abdomen with signs of guarding, which is typical for a perforated peptic ulcer. In case of a perforated peptic ulcer, the patient usually lies motionless and is having a rigid and tender abdomen with signs of guarding. So this is typical for perforated peptic ulcer. Now, perforation of a gastric or duodenal ulcer is usually a severely painful sudden event. It may occur in those without known peptic ulcer disease as well as those with previously diagnosed problems. However, close questioning may reveal recent symptoms attributed to indigestion. Sudden localized epigastric pain spreads to the remainder of the abdomen. The pain is sudden localized epigastric pain spreads to the remainder of the abdomen, and the pain is usually worse on coughing or moving. Therefore, the patient lies motionless, and this pain may radiate to the tip of the shoulder as well. Now, although the patient is distressed, uh, in examination, although the patient is distressed, the patient often prefers to lie still and rather than rolling about in case of perforated peptic ulcer. And there are absent bowel sounds, shock, generalized peritonitis, and fever may develop as the time passes. Absent bowel sounds, shock, generalized peritonitis, and fever develops as time passes. Now, investigations. An erect chest X-ray will demonstrate free gas under diaphragm. So, investigations would be like an erect chest X-ray, which will demonstrate free gas under the diaphragm. In those cases where the diagnosis is suspected but not proven by X-ray, a contrast CT scan may help. So either we can carry out an erect chest X-ray in which we will see free gas under the diaphragm, and but in those cases where the diagnosis is suspected and in X-ray we don't see any finding, in those cases we can carry out a contrast CT scan. Now treatment is providing IV analgesia, giving an antiemetic, that is IV metoclopramide 10 mg, resuscitation with IV 0.9% saline. So fluid resuscitation with IV 0.9% saline, and refer the patient to the surgeon and give IV antibiotics. So this is about perforated peptic ulcer. This patient here is clearly a case of an acute abdomen, and the X-ray is showing free air under the diaphragm, which is classical for a perforation case. Patient is lying motionless, having tender rigid abdomen with guarding, which is typical for a perforated peptic ulcer. Now, perforation of a gastric or duodenal ulcer is usually a very sudden, severe, painful event. It can occur in those with known disease, known peptic ulcer disease, or those with undiagnosed problems. And in this, there is sudden localized epigastric pain which spreads to the remainder of the abdomen, become generalized, and this pain is usually worse on coughing and on movement. Therefore, the patient lies motionless, and this pain may also radiate to the tip of the shoulder. The patient prefers to lie still, motionless rather than rolling, and absent bowel sounds, shock, generalized peritonitis, and fever. So, absent bowel sounds, generalized peritonitis, fever, shock, these are the things which may develop as time passes. Investigation would be erect chest x-ray, which is showing or demonstrating free gas under diaphragm, or if the diagnosis is suspected or it is not proven by x-ray, then we can carry out contrast CT scan. Treatment is providing IV analgesia because it is very painful, then giving antiemetics like IV metoclopramide 10 mg, then resuscitation of the patient with IV fluids like 0.9% saline. So fluid resuscitation is also important here. Fluid resuscitation with 0.9% saline, and refer the patient to a surgeon and give IV antibiotics as well. So IV antibiotics are also given and refer the patient to a surgeon. So these are the things. Let's move ahead now. Now we have a 61-year-old man presenting with fatigue and palpitations. His past surgical history includes an ileal resection which was performed 1 year ago. A full blood count was requested and the results are showing hemoglobin to be 93, MCV to be 111. What is the single most likely diagnosis? So here we are seeing that the patient is having high MCV and low hemoglobin, that is macrocytic anemia. So if the patient is having, if mean cell volume is high, hemoglobin is low, it is macrocytic anemia. These findings, together with a history of ileal resection where malabsorption of B12 can occur, point towards the diagnosis of B12 deficiency. Vitamin B12 deficiency is the answer here. So we have to compare here the causes of folate deficiency and B12 deficiency. See, folate deficiency and B12 deficiency. B12 deficiency can occur mainly because of inflammation of small intestine as well as due to gastric resection. But folate deficiency occurs due to inflammation of small intestine. Can be Crohn's disease, celiac disease, tropical sprue. But the most common cause for vitamin B12 deficiency is pernicious anemia. So pernicious anemia, most common cause, and dietary cause can be vegan diet because it is mainly found in dairy products, fish and meat. And another cause is following total gastrectomy because body stores of cobalamin can deplete after 1 to 2 years of surgery. Then ileal disease like ileal resection of ileum or Crohn's disease. Then another cause is malabsorption disorders like celiac disease or tropical sprue. So these are the causes. And abnormalities which we see hematologically are macrocytic anemia. MCV is usually more than 110. Hypersegmented neutrophils. Homocysteine levels are high. all these things are seen in both folate as well as B12 deficiency here, but serum B12 will be low, obviously. Management, hydroxycobalamin intramuscularly. Chronic anemia symptoms would be seen like dyspnea and effort, fatigue, neurological symptoms like classically peripheral paresthesia and disturbances in vibration and position sense. If uncorrected, patient may develop subacute combined degeneration of spinal cord leading to permanent ataxia, which we've already read about this earlier. So let's move ahead. Now we have here a 58-year-old man having a history of moderate to severe recurrent epigastric pain at night for the past 3 months. He has no history of peptic ulcer diagnosed previously, no previous investigations for dyspepsia. He takes regular ibuprofen over the counter for his knee pain. On the examination, he has tender upper abdomen. His heart rate is 85, blood pressure is 95/65. Single most appropriate investigation that would lead to a diagnosis here in this case. So the key point here are that he takes regular ibuprofen and has a tender abdomen. So peptic ulcer would be high on the list of differentials. Now, since this question is asking for an investigation which will lead to a diagnosis, endoscopy is the best answer to investigate for a peptic ulcer. So peptic ulcer, in case of peptic ulcer, we have to carry out endoscopy. In case of dysphagia, initial investigation is endoscopy, and dysphagia and specific investigation, then according to diagnosis, acute upper GI bleed, regardless of the age, we have to go for endoscopy. So in all these cases, like most initial investigation in case of dysphagia or in case of peptic ulcer disease, or in case of acute upper GI bleed, regardless of the age of the patient, in all these cases, we have to go for endoscopy. And in case of dyspepsia, if the patient is above 55 years of age, then we can carry out endoscopy. And if patient is less than 55 years of age, then we can carry out test for H. pylori. The patient here is 58 years old. So more than 55 years of age, we have to carry out endoscopy in this case. That should be remembered. So if the patient's age is more than 55 years, carrying out endoscopy is a wise option because he's at higher risk. And less than 55 years, here answer could have changed to testing for H. pylori. Now let's study a little about dyspepsia and endoscopy. Nice has clearly given clear guidelines on which patients should be offered a GI endoscopy. Early detection of esophageal cancer and stomach cancer is important. So we have to offer urgent upper GI endoscopy in patients with dysphagia, second, 55 years and over, with weight loss and any of the following symptoms such as dyspepsia, reflux or abdominal pain. So one is uh, having dysphagia, second is 55 years and over of age, 55 years and more age with weight loss and any of the following symptoms such as reflux, dyspepsia and upper abdominal pain. So the other times to arrange a routine upper GI endoscopy is there are refractory or recurrent symptoms of dyspepsia despite optimal management, usually 4 weeks of proton pump inhibitors, or treatment with a second line H. pylori eradication regimen has been unsuccessful. In those cases, also upper GI endoscopy has to be arranged. We have to ensure the person stops any acid suppression therapy for at least 2 weeks before the endoscopy date. Antacids and alginate therapy can be used during this period. So 4 weeks of proton pump inhibitors, and despite optimal management, nothing is working out. Patient is having refractory recurrent symptoms of dyspepsia, then we can conduct endoscopy. Or if second line H. pylori eradication regimen has been unsuccessful. So these are another cases. Now let's move ahead. Now we have here a 30-year-old lady complaining of intermittent diarrhea. So a 30-year-old lady complaining of intermittent diarrhea, chronic abdominal pain and tenesmus. Sometimes she notices blood in her stool. What is the single most likely cause of her symptoms? So inflammatory bowel disease is the best choice here, where we are having options like inflammatory bowel disease, diverticulosis, irritable bowel disease, adenomyosis, endometriosis. Because all the symptoms stated in the question, including tenesmus, can occur in inflammatory bowel disease. They have given symptoms like diarrhea, chronic abdominal pain, tenesmus, blood in her stool. So the answer is unlikely to be diverticulosis, which is defined as the presence of diverticula, which are asymptomatic. The patient has symptoms here clearly. Blood in stools is not seen in irritable bowel disease. And remember, passing blood is not a symptom of irritable bowel syndrome. So blood in stools is not seen in irritable bowel disease or irritable bowel syndrome. Blood in stools is seen in inflammatory bowel disease, mainly ulcerative colitis. Symptoms are not at all consistent here with adenomyosis or endometriosis. So if there is blood in stool, it is inflammatory bowel disease. No blood in stool, then irritable bowel disease. Kind of can be remembered like that. In this case, but we should also remember that inflammatory bowel disease includes both Crohn's disease as well as ulcerative colitis. Diverticulosis, on the other hand, is reported in patients with more than 60 years of age, which are asymptomatic initially, but advanced cases it may cause painless hematochezia or diverticulitis. So inflammatory bowel disease, ulcerative colitis and Crohn's disease, irritable bowel syndrome, there will be bloating, constipation alternating with diarrhea. In irritable bowel syndrome, there will be constipation alternating with diarrhea, and there will be bloating and no blood in stools. Constipation alternating with diarrhea, bloating, and no blood in stools. That is inflammatory bowel syndrome. So let's move ahead. Now we have a 21-year-old woman complaining of diarrhea, abdominal cramps for the past 5 months. She says that her diarrhea has recently become bloody. A rectal biopsy was performed and histology was reported as decreased amount of goblet cells. What is the single most likely diagnosis here? So this is clearly a case of ulcerative colitis. Decreased goblet cells on histology points towards ulcerative colitis, and her diarrhea has also recently become bloody. So this is another thing which is giving away the answer. We have to remember Crohn's disease can affect any part of the GI tract from mouth to anus, and usually non-bloody diarrhea is there. And abdominal mass is palpable in right iliac fossa. Increased goblet cells and increased granulomas on histology. Weight loss is more prominent. Transmural skip lesions and cobblestone appearance on endoscopy. Transmural skip lesions and cobblestone appearance on endoscopy, whereas in ulcerative colitis, it affects the mucous membrane starting from the rectum in colon, uh, mainly affecting the colon, and affects the mucous membrane starting from rectum. Sorry. Now, here bloody diarrhea is more common compared to Crohn's disease. Abdominal pain is felt in the left lower quadrant, not in the right lower quadrant, and there is decreased goblet cells and decreased granulomas on histology. Primary sclerosing cholangitis is more common. There is loss of hostrations, loss of hostral markings. Drain pipe colon is seen on barium enema. Cobblestone appearance is seen on endoscopy in Crohn's disease. Transmural skip and skip lesions. So that is a brief comparison which we have already seen earlier as well. This table here is very important. Skip lesions anywhere in the GIT, continuous lesions only affecting colon, non-bloody diarrhea, bloody diarrhea, transmural ulcers, granulomas, crypt abscesses. Then complications here are like fistula, strictures, osteoporosis, colorectal cancer. Here it is colorectal cancer, osteoporosis, and toxic megacolon. Endoscopy, here we see cobblestone appearance. Here on barium enema we see loss of hostile markings, drain pipe appearance. Here in Crohn's disease, treatment is with glucocorticoids, azathioprine, mercaptopurine, infliximab, adalimumab. Glucocorticoids, then adalimumab, infliximab, and azathioprine and mercaptopurine. Here treatment is with mesalazine, corticosteroid, cyclosporin. That's a quick run through of comparison. Now let's move to the next question. We have a 47-year-old woman diagnosed with celiac disease at the age of 3 who has recently developed diarrhea and weight loss for the past 3 months. What is the single most likely reason for this? Now, here we have to remember the complications or the risk associated with celiac disease. One of them is intestinal lymphoma, because the patient is having weight loss here. So, it is pointing towards lymphoma of his small intestine. One must remember the cancer risk associated with celiac disease. Although it is very less common, but there are chances. And the cancer risk is associated with celiac disease, and it is intestinal lymphoma. Intestinal T cell lymphoma is the kind of cancer associated with celiac disease. Complications can be iron deficiency, folate deficiency, vitamin B12 deficiency, hyposplenism, osteoporosis, T cell lymphoma, esophageal cancer, and other malignancies. So, complication of celiac disease can be remembered like an old dead anemia, folate deficiency, iron deficiency, vitamin B12 deficiency anemias, then osteoporosis, then lymphoma, then dermatitis herpetiformis, and diabetes mellitus. Diabetes mellitus is also associated with celiac disease. It is also a complication. Dermatitis herpetiformis is also associated with this. Then anemias, then osteoporosis, and T cell lymphoma. An old dead, that can be used to remember the complications of celiac disease. N for anemias, O for osteoporosis, L for lymphoma, D for dermatitis herpetiformis, then another D for diabetes mellitus. Now let's go to the next question. A 24-year-old female presenting with a 4-month history of bloody diarrhea. Along with that, she has lethargy and weight loss. She complains of abdominal discomfort, passing stools more than 8 times in a day. Endoscopy was performed, which shows deep ulcers and skip lesions. What is the single most likely diagnosis here? So, diagnosis of Crohn's disease is quite clear because the patient here is first showing lethargy and weight loss, which are non-specific signs, but they can occur in Crohn's disease. The giveaway here are the deep ulcers and skip lesions. These deep ulcers and skip lesions are characteristic features, and these are seen on endoscopy, which is pathognomonic for Crohn's disease. And we also have to note that all the Crohn's disease usually has non-bloody diarrhea. Sometimes, occasionally, it can present with bloody diarrhea as well, like in this case. So, deep ulcers and skip lesions. These are pathognomonic endoscopy findings of Crohn's disease. Even though bloody diarrhea is present, it's still a case of Crohn's disease. Let's study a little about the management of Crohn's disease now. In Crohn's disease also we have two parts, inducing remission and maintaining remission. Inducing remission involves corticosteroids. Now if corticosteroids are contraindicated, then we use budesonide or aminosalicylates like mesalazine for mild to moderate disease. So mnemonic is C for Crohn's disease, C for corticosteroids as the first line to induce remission. If corticosteroids are contraindicated, then we use budesonide or aminosalicylates like mesalazine for mild to moderate. For maintaining remission, the medication used for this maintaining remission are azathioprine, mercaptopurine, and methotrexate. Azathioprine and mercaptopurine and methotrexate. C for Crohn's disease, C for corticosteroids. So now let's move ahead. Now we have a 55-year-old woman complaining of retrosternal chest pain, difficulty in swallowing which is intermittent and unpredictable. She says that food gets stuck in the middle of the chest. She has to clear it with a drink of water. She is then able to finish the meal without any further problem. A barium meal shows a corkscrew patterned esophagus. What is the single most likely cause of dysphagia here? So for dysphagia, we have to remember few things. First is it is of two types, motility problem and mechanical obstruction. Motility problem, further they are divided into two types, intermittent and progressive. In motility problem, intermittent is diffuse esophageal spasm and progressive is achalasia and scleroderma. In mechanical obstruction, intermittent is esophageal ring, progressive is esophageal cancer and peptic stricture. Now, motility problem, here dysphagia is to both solids and liquids in motility problem. In case of diffuse esophageal spasm, achalasia and scleroderma. Whereas in mechanical obstruction, dysphagia is initially to solids, but it later progresses to involve liquids as well. That is in case of esophageal ring, esophageal cancer, and peptic stricture. So that should be remembered. So here the characteristic feature corkscrew pattern gives it away that this is a case of diffuse esophageal spasm. Corkscrew pattern appearance in barium enema is a characteristic feature pathognomonic for diffuse esophageal spasm. Bird's beak appearance. Corkscrew pattern or bird's beak. Bird's beak is actually seen in achalasia, sorry. Corkscrew pattern is seen in barium enema finding of diffuse esophageal spasm, and bird's beak appearance is seen in barium enema, barium swallow. Sorry, barium swallow finding in both. Corkscrew appearance is seen in barium swallow finding of diffuse esophageal spasm, and bird's beak appearance is seen in barium swallow finding of achalasia. And the dysphagia here is intermittent type. Dysphagia in stricture is actually benign esophageal stricture is actually continuous type, whereas here it is intermittent type. Progressive is in cancer. Now let's move ahead. So now, gastroenterology, in this next scenario, we have here a 15-year-old child complaining of right iliac fossa pain worsening over the past few weeks. He also has bouts of diarrhea coming in episodes for more than a year. He has lost 7 kgs in last 5 months. On examination, we see perianal skin tags. He was referred to gastroenterology team. Colonoscopy was performed. And this colonoscopy shows deep ulcer and skip lesions on colonic mucosa. What is the single most appropriate management is being asked here. So this is a case of Crohn's disease, and if management is being asked, so obviously we know in the management of Crohn's disease, corticosteroids are used in the first line to induce remission. If they are contraindicated, we use budesonide or aminosalicylates like misalazine. For maintaining remission, we use azathioprine or captoprine, other such drugs. So here prednisolone would be the answer, which is a glucocorticoid, glucocorticosteroid. As we read, corticosteroids are used in the Crohn's disease management, so prednisolone would be the answer here. The diagnosis is quite clear. Skip lesions gave it away. Supported by weight loss, perianal skin tags, glucocorticoid like corticosteroid like prednisolone orally would help in inducing the remission. Now let's move ahead. Now we have here a 61-year-old man brought to the emergency with a 2-day history of epigastric pain, constant vomiting. He has been vomiting bright red blood, has a medical history of rheumatoid arthritis, has been taking naproxen and prednisolone. On examination, he has a very tender epigastrium. Blood pressure 160, heart rate 101, was given IV fluids. What is the primary diagnostic investigation for this patient? So the patient here has an acute upper GI bleed. This may be linked to the use of naproxen, NSAIDs, and corticosteroids, which are part of management of rheumatoid arthritis. These NSAIDs are notorious for their tendency or propensity to cause gastric ulceration, which likely leads to erosion of a blood vessel. An urgent endoscopy should be arranged to look for the source of bleeding and stop it. Acute upper GI bleeding has a high risk of mortality, so endoscopies need to be arranged quickly. An erect chest X-ray is useful in peptic ulcer in the acute setting as it allows the diagnosis of pneumoperitoneum if there is a perforation. As the patient stands erect, the air leak from inside the GI tract will float to a position underneath the diaphragm. It is less useful compared to an endoscopy since one cannot treat the patient. Endoscopy allows identification of the source of bleeding as well as treatment of the source of bleeding. So the important lesson here is endoscopy is the investigation of choice in an acute upper GI bleed. It is not erect chest X-ray. So Again, in case of an acute upper GI bleed, which can be linked to the use of NSAIDs, corticosteroids, which are used in management of rheumatoid arthritis. These NSAIDs, as they have tendency to cause gastric ulceration, they can lead to erosion of a blood vessel, can lead to bleeding, upper GI bleeding. Now, an urgent endoscopy should be arranged to look for the source of bleeding and stop it. An acute upper GI bleeding case has a high risk of mortality, so endoscopies need to be arranged quickly. He has been vomiting bright red blood. That was given in the question. Now, an erect chest X-ray is useful in peptic ulcer in the acute setting, which helps in the diagnosis of pneumoperitoneum if there is a perforation. As a patient stands erect, the air leak from inside the GI tract will flow to a position underneath the diaphragm. So it can lead to pneumoperitoneum if there is perforation, but it is less useful compared to an endoscopy because here we cannot treat the patient. Whereas in endoscopy, apart from identification of the source of bleeding, we can also treat the source of bleeding. So, takeaway point is endoscopy is an investigation of choice in case of an acute upper GI bleed. This patient has upper GI bleed, constantly vomiting, hematemesis, needs to be resuscitated with IV fluids, was probably in shock. Upper GI endoscopy plus treatment. If patient had history of vomiting of blood, no ongoing upper GI bleed, then there is no need of resuscitation on presentation. Then erect chest X-ray can be done. So let's move ahead. Now we have a 58-year-old man presenting with lump in the left supraclavicular fossa. This has been present for last 6 months. The lump is firm. He also complains of dyspepsia and loss of weight, which he accounts for due to his reduced appetite. What is the single most likely diagnosis here? So the lump in the left supraclavicular region is known as Virchow's node, and this finding is called as Trocher's sign. It is indicative of the carcinoma of stomach since it is one of the first visible spots where metastasis occurs. The weight loss, decreased appetite support the diagnosis of gastric cancer. Another differential here, Hodgkin's lymphoma for supraclavicular lymphadenopathy, but it is most commonly presenting with cervical lymphadenopathy. So this is a case of gastric cancer. The lump present in the left supraclavicular region is known as Virchow's lymph node. It is the Virchow's node, and this finding is called as Trocher's sign. So in gastric cancer, in gastric carcinoma, presence of a lump in the left supraclavicular region due to metastasis, it is known as Virchow's node, and this finding is called as Trocher's sign. Finding of this Virchow's node, this finding is called Trocher's sign, and it is indicative of carcinoma of stomach. It is the first visible spots where metastasis occurs in this case, and weight loss and reduced appetite are supporting the diagnosis of gastric cancer here. In Hodgkin's lymphoma, There is cervical lymphadenopathy instead of supraclavicular lymphadenopathy. So Trocheus sign, left supraclavicular mass, that is Virchow's node, whereas Trocheus sign is carpopedal spasm in latent tetany, and Trocheus syndrome is migratory thrombophlebitis. So we have to remember all these three. Trocheus sign is finding of left supraclavicular mass in gastric cancer, that is finding of Virchow's node, and Trocheus sign is carpopedal spasm in latent tetany. Trocheus is carpopedal spasm in latent tetany, and Trocheus syndrome is migratory thrombophlebitis. Trocheus syndrome is migratory thrombophlebitis. Now, Virchow's node is normally found at the junction of the thoracic duct and left subclavian vein in every healthy person. Tumor embolization, however, leads to its enlargement and recognizability as a mass. That is called Trocheus sign, clinical appreciation of the Virchow's node as a mass. At this point, some call it as Trocheus node, differentiated from the normal Virchow's node. So Virchow's node is normally found in even a healthy person at the junction of the thoracic duct and left subclavian vein. At the junction of thoracic duct and left subclavian vein, but due to metastasis or tumor embolization, it leads to the enlargement of this Virchow's node, and it is recognized as a mass, left supraclavicular mass. And this finding is called as Trocheus sign, the clinical appreciation of this Virchow's node as a mass. Left supraclavicular mass is in stomach cancer, right supraclavicular mass is in esophageal cancer, lung cancer, and Hodgkin's lymphoma. So left supraclavicular mass is seen in stomach cancer or gastric cancer, gastric carcinoma, and right supraclavicular mass is seen in esophageal cancer and lung cancer. Left is seen in stomach, right is seen in esophageal cancer and lung cancer. Now let's study about another differential here, which is a Pancoast tumor. Pancoast tumor is a tumor of the pulmonary apex. It is a type of lung cancer defined primarily by its location. Situated at the top end of either the right or left lung, it typically spreads to nearby tissues such as the ribs and vertebrae. Most Pancoast tumors are non-small cell cancers. So Pancoast tumor is a tumor of the pulmonary apex, type of lung cancer. Okay, so let's move ahead. Now we have here a 46-year-old woman presenting with sudden episode of abdominal pain which started about 5 hours ago. The pain is in the epigastrium radiating to back. Now she has vomited twice. Since the onset of the attack, the pain is made worse by lying flat on her back, and she is more comfortable sitting up, bending forwards. She was informed of the presence of gallstones in her gallbladder 4 weeks earlier when she reported pain in the right hypochondrium. Temperature 38.4, blood pressure 120/85, pulse rate 115. No presence of jaundice, but there is marked tenderness in the epigastrium. So this is a case of pancreatitis, what is the single most appropriate investigation here? So, the likely diagnosis is acute pancreatitis, and serum amylase and lipase are appropriate investigations looking for an elevation of more than 3 times the upper normal limit. While abdominal x rays are not useful in the diagnosis of pancreatitis, they are routinely ordered to exclude out other potential causes of abdominal pain, such as perforation or bowel obstruction. Ultrasound is useful to detect the presence of gallstones, but it is not a good diagnostic test for acute pancreatitis. It is poorly visualized in ultrasound. Urea electrolytes, liver function tests do not directly aid the diagnosis of pancreatitis. However, they are helpful in assessing the severity and the extent of the disease by showing the degree of leukocytosis or hypovolemia, giving clues to the etiology of pancreatitis, that is, gallstone pancreatitis. So, serum amylase and serum lipase are the most appropriate investigations in a case of acute pancreatitis. We have to see for an elevation of more than 3 times the upper normal limit. Abdominal x-ray is not useful in pancreatitis, but it can be used for excluding other potential causes like perforation and obstruction. Ultrasound not useful, but it can be used for detection of presence of gallstones. Urea electrolytes and liver function tests do not help directly aiding in the diagnosis of pancreatitis, but can be used for assessing the severity and extent of the disease and giving clues about the etiology of pancreatitis, like gallstone pancreatitis. So now let's take a break for a while and I'll be back.